your lunch, will be enjoying your postprandial siesta, and those of you who have yet to eat will be ready to hurry off to get what little there is left. So I won't take very long. I've been given 15 minutes by the organizers to compare between spinals, epidurals, and lumbosacral plexus blocks for knee surgeries. As all of you know, there are a variety of knee surgeries being performed. Primarily, you can have either diagnostic or therapeutic knee joint arthroscopies and knee arthroplasties. The introduction of knee joint arthroplasty into clinical practice has widely been regarded as one of the most significant advances in orthopedic surgery. Millions of patients the world over are diagnosed with disabling arthritis necessitating knee joint replacements, and this particular surgery is being done with increasing frequency in centers across our country also. Coming to the innovation of the knee joint, the femoral nerve supplies the anterior aspect of the knee via the branch to the vastus medialis, and the sciatic nerve supplies the posterior aspect of the knee joint capsule and all the intra-articular structures via the genicular branches of both the tibial and peroneal components. The posterior division of the obturator nerve also contributes to innovation of the knee joint. So the goals of anesthesia for knee joint surgeries, like for any other surgery, would be to have stable intraoperative conditions with minimal side effects, and in addition, you would like to have a minimal motor block that extends into the postoperative period, facilitating rapid functional recovery through effective and early joint rehabilitation. And there is enough evidence to state that a well-conducted regional anesthesia satisfies all these goals. A knee joint arthroplasty, if you ask any patient who has undergone one, he will say or she will say that is the most painful experience they have ever had. So this is a very, very, very painful surgery demanding excellent postoperative analgesia. And this is because you have multiple osteotomies. The quadriceps is split during the procedure, and you will agree with me when I say that no one regional anesthesia technique has become universally popular. This would intuitively mean that all these techniques have either certain side effects or significant limitations. So these are all the options that you can have when you perform a knee surgery. You could do a continuous femoral block with or without obturator and sciatic blocks. You could do a continuous lumbar plexus block with or without sciatic block, a single shot femoral or single shot lumbar plexus block, continuous epidural analgesia, which used to be the gold standard earlier, a single shot subarachnoid block with intrathecal morphine, high volume local infiltration analgesia, which is coming into vogue, and of late there's been a lot of talk on adductor canal blocks. I'll quickly review the evidence for spinals, epidurals, and lumbosacral plexus blocks for knee joint arthroplasties, this being the most painful of knee surgeries. In this particular study, a single injection ultrasound-assisted femoral nerve block was compared to intrathecal morphine. 250 micrograms of preservative-free intrathecal morphine was given, and they looked at various variables. And the authors concluded that there were lesser side effects with femoral nerve block than compared to intrathecal morphine, which translates as lesser patient satisfaction in the intrathecal morphine group. And you must remember that in this particular study, adjuvants in the form of epinephrine and clonidine were used to prolong the block of the femoral nerve. There is not very compelling evidence in favor of intrathecal morphine for post-op analgesia following knee arthroplasties, and the correct dose also has not yet been clearly defined. In this particular study, 200 micrograms versus 500 micrograms of preservative-free intrathecal morphine was studied, and it was seen that the adverse effects were the same in both the groups, and it was also concluded that 500 mics of intrathecal morphine gave better post-op analgesia when compared to 200 mics. So spinal anesthesia is the preferred form of anesthesia for knee surgery. Intrathecal opioids, as we know, act on the mu receptors in the white matter and the dorsal horn of the spinal cord. The incidence of post-op nausea and vomiting is 35%, which is comparable to that of systemic opioids. The incidence of pruritus and urinary retention is 30%, which is again comparable to that with systemic opioids. And we must remember that when you use intrathecal morphine, this being a hydrophilic drug, there is a possibility of rostral spread. Therefore, in a patient having received intrathecal morphine, if this particular patient is unduly sedated in the post-op period, please keep in mind that this is an impending warning signal of respiratory distress. This was published in 2013, epidural analgesia for pain relief following hip and knee replacements, and this was compared with systemic opioids. And the conclusions were that epidural analgesia is definitely useful in the first 6 hours, and it is useful for dynamic analgesia, and it was also concluded that epidural infusion of local anesthetic and narcotic was better than narcotic alone. In this particular study, epidural analgesia was compared with a combined femoral sciatic nerve block after total knee replacement, and it was seen that there were more side effects in the epidural group, and there was, for obvious reasons, motor block of the non-operated limb in the epidural group. And this was a prospective randomized controlled trial in which continuous femoral nerve block was compared with epidural analgesia following a total knee replacement, and it was seen that there were reduced side effects in the continuous femoral nerve block group, and the pain scores were equal both at rest and on dynamization in both the groups. A word about epidural anesthesia. The timing of epidural placement in relation to the low molecular weight heparin prophylaxis is very crucial. We must ensure a 12-hour window. And complementary analgesia, unfortunately, of the non-operated limb is possible with epidural. And there is urinary retention which necessitates bladder catheterization, especially in elderly patients. And delayed functional recovery can be there if you do not titrate your local anesthetic concentration and volume judiciously. In this study, for total knee arthroplasties, a single injection or a continuous lumbar plexus block was combined with a sciatic nerve block both for surgical anesthesia and post-operative anesthesia in about 44 patients. And there were low scores in pain in the continuous lumbar plexus block group for obvious reasons. And this was the comparison of ropivacaine and bupivacaine for lumbar plexus and sciatic nerve block, not a very exciting study. This was an interesting study in which the patient satisfaction and effectiveness of lumbar plexus and sciatic nerve block for total knee arthroplasty was looked at in 87 patients for both intraoperative and postoperative analgesia. 16 out of 87 patients had to be converted to GA, which is a fairly significant rate of 22%, and it was 13 hours before any patient required a rescue analgesic. This was again a study where you had 3 groups of patients, in which there was a comparison of continuous versus single injection lumbar plexus block, and this was compared with rescue analgesic with morphine, and for obvious reasons again in the continuous block group there was a reduced requirement of rescue analgesia. And here there were 3 groups. In one group you had a continuous femoral and sciatic block, in the other group you had a continuous lumbar plexus block, and in one group you had a continuous femoral block alone, and analgesia was significantly better in the group in which both femoral and sciatic blocks were given on a continuous basis. Now this is a question uppermost in our minds when we want to do a sciatic nerve block for knee joint arthroplasties. This is because the incidence of sciatic nerve palsy following a total knee arthroplasty is 2.6%. So when there is a foot drop in the post-op period, the surgeon does not know whether to attribute it to a wonderfully acting block or whether he had buggered the nerve during the procedure. And you must also remember that post-op mobilization or dynamization of the patient is not possible till the foot drop has worn off. So that again delays physical therapy in the post-op period. So to block or not block the sciatic nerve is often an important question. And this was a systematic review in which it was looked at whether a sciatic nerve block when combined with a femoral nerve block is advantageous following a total knee arthroplasty, and the authors concluded that beyond 24 hours, there is no compelling evidence in favor of a sciatic block. But having said that, in this day of evidence-based medicine, absence of proof is not the same as proof of absence. So what you would like to do is have your own institutional guidelines which are best suited for your patient populations and that meet best the demands of your surgeons. So I conclude by giving to you my institutional practice. We use spinal anesthesia for all unilateral knee joints. We use epidural anesthesia only for bilateral total knee arthroplasties, and we've convinced our surgeons not to do both the knees at a single setting anymore. We do not do sciatic nerve blocks, certainly no lumbar plexus block, because I believe it is an overkill. And femoral nerve blocks was something we used to do earlier. We used to put femoral nerve catheters, now we don't. Off late, we have started performing an ultrasound-guided adductor canal block, and the surgeons do a single-shot, high-volume local infiltration analgesia. And post 24 hours, we treat the patients with oral paracetamol, NSAIDs if permissible, and we've started using transdermal fentanyl patches, which we see work wonderfully in these patients. Thank you very much for your attention.
Thank you. All the speakers done a wonderful job, and I think this comparison was the beautiful comparison which really opens the eyes that which choice should be made.